Hey, thank you, Jordan. So we're not going to go too far into the future. I mean, it really just right now, there's not that many centers that have AI installed and active, and even fewer that are doing it in ways where they're super excited about it and saying this is really helping. So we're going to take a kind of look into the near future as where things might move. And that's kind of how I'll get started here. Okay, so these are my disclosures. And this is what we'll cover. So we'll talk about key factors for success in radiology, put a framework in place across these other things that we're going to talk about, like deep learning image reconstruction, AI triage, natural language processing for reporting, opportunistic screening, which was just kind of mentioned there about like looking at organs and so forth, and then augmented intelligence, specifically as it applies to advanced cancer as an example. So what are the key factors for success? I think these are it here, where you have to have some sort of clinical value. We'll define these in a moment. It's got to be super simple and then have a return on investment. And we'll use ROI as an abbreviation for that. So clinical value could be improving patient outcomes, increasing accuracy, reducing errors, and these kind of things. Something that's clinically meaningful to us. Simplicity is, just as I said, probably the easiest way to say it is just super easy to use. It's also nice if it's easy to install, but more important, at the user level, minimal training required. And wow, this is just so intuitive and easy. That's kind of key. It may be the most important thing in the current landscape that we're in right now, but in the future, these other things are going to come into play. And it has to show a return on investment. So this new revenue, most of the time there's not new CPT codes. So it has to do something like increase radiologist efficiency dramatically or increase throughput. And sometimes there's other things that it can do, downstream billing that it can create. And I'll show you an example of that in this talk. So we'll have like an AI scorecard that looks something like this with clinical value, simplicity, and return on investment. A perfect score would be 10 across all of these. So let's do deep learning image reconstruction, or DLIR, just as an example. So to get a great looking PET scan, you have to give a full radio tracer dose and do a full scan time to get good looking images. If you cut the radiation dose by a fourth, then you're going to get noisy looking images and have poor signal to noise. Conversely, if you keep a full radiation dose but cut the scan time to 1/4, like 20 minutes down to 5, you're going to get similar looking images that are noisy. And deep learning image reconstruction allows us to regain that signal to noise. It essentially reduces the image noise, which can be really beneficial. So if you think about like how you could use this, now a 5-minute PET scan may be achievable as opposed to like a normal roughly 20-minute scan, depending on your scanner. So you could have higher throughput and increase patient satisfaction. You know, it's just easier to lay in a bed for 5 minutes than it is for 20. You could also cut that radiation dose down, which lowers the radiation exposure, which is important in young patients. And then that may open up some new opportunities. Maybe there's some new radio tracers that give really poor signal, but now because you can improve the signal to noise, you might be able to detect them better. So here's how I kind of score this one. A clinical value of 4. Why? Because yes, we are increasing patient satisfaction and better scan quality, maybe reducing radiation dose in the young, but that's not really changing a lot clinically. So I gave that like a score of 4. Simplicity, most of these algorithms are fairly easy if they're already on the scanner to deploy, but they're difficult to operationalize. So think about it. You have to have enough radio tracer uptake rooms. You still have to do your like hour of radio tracer uptake, even for your 5-minute scan. So you have to have more rooms, and you have to have slots on the scanners to be able to accommodate these faster scans, or you really don't benefit from them. So that's why the return on investment is variable, because if you can't accommodate or operationalize this, you're not going to gain the return on investment that you were looking for. This is very similar for MRI. So let's just pretend a classic scan has multiple sequences in it and is 25 minutes. In the old days, if we wanted to do that, a fast scan, we do an abbreviated protocol, like a biparametric prostate is an example of that, which would be like a 5-minute exam. What's coming down the pipeline right now, it's just not universal across all types of exams, but there are now exams that are 5 minutes where we shorten each of these using deep learning image reconstruction. So I'll show you an example of this. These images look very similar, but the one on the left was a traditional 4-minute scan, while the one on the right is a 40-second scan, which is about 6 times faster. So that makes a big difference to be able to do this quicker. And if you could do that across all sequences, you might have a 5-minute scan, which would just be more tolerable. I don't know if you've ever sat in an MRI scanner, but it's not a lovely thing to do. And some of these patients are in pain or just have other problems with their back or breathing issues. So getting through these exams quickly is a bit more important, I think, on MRI. So in terms of scoring this a little bit differently, I gave it a slightly higher clinical value. So it's increasing patient satisfaction. This reducing of motion artifacts is probably more important in MRI because of those faster scan times. And it might open up some new opportunities for MRI that we weren't able to do before, and now we can because it's faster. It's relatively simple, again, to deploy, but this one's even more difficult to operationalize because you have multiple MRI scanners and you'd have to have some way of having these super short slots. Now, this is just the scan time, 5 minutes. So maybe your slot time could get down to 15, maybe 20 minutes realistically. If you're already at 30, that can be difficult to operationalize. The last thing is the return on investment. If you can operationalize it, you can have a tremendous return on investment because of the cost of MRI. So there's a very wide variability there depending on how well you can operationalize this on your scanner. Let's move on to a different topic then. CAD-T is computer-aided detection and triage. And so this is like AI triage is another way of saying this. So here's a classic CT pulmonary angiogram study, and you can actually see the pulmonary embolus here. That's not actually the point, though. The real point is to get this to come off the scanner and instantly get notified. So we often have these things called widgets, and it can be just a little tiny box floating on your window, and it will pop up with information. This is everyone that had a positive study, and over here is in context the patient that is positive right now. And you can do these cool colored maps or saliency maps to get an idea, oh, this is where it's positive. Now, it does not directly interact slice by slice with your PACS, but in general, you can go ahead and find this. So I'm not getting a region of interest around this in my PACS. I'm seeing it on the widget. So that just calls into question, how strong is this bond between the AI and human using a widget? Here's what we originally thought. This is literally what I told our administrators that we were going to be able to potentially do. I said, I think we're missing about 100 PEs a year on dedicated exams, and that these are high risk and could lead to some fatalities and missed care opportunities and so forth. So I painted this doomsday thing, and I said, hey, AI is probably going to get us down to under 5 of these things, and that's really going to help patients and improve quality of care and so forth. We decided to test this. So we did a prospective study. Kind of phase 1 is where the AI is working in the background, but blocked from interacting with the human. And then phase 2, after a warm-up period and getting used to it, the AI and human are interacting with one another. And we were kind of surprised, not too surprised, but the accuracy did not go up significantly. We're already very high accuracy, and this maybe 1% change may not even be real. It's just sampling size, so didn't get a significant p-value. More importantly, with the widget, we did not get an improvement in the turnaround time. And that was very disappointing. This is actually what it's FDA cleared to do, is improve your turnaround time. So it made us question a lot of things. How strong is the AI to human interface with a widget? And did we have unrealistic expectations at a center with 24-hour coverage and fairly fast turnaround times in the first place? So if I had to redo this slide, it would look something like this. We're not quite missing 100. We're missing more like 60. And of those, it turns out when we looked at the data, it's mostly clinically insignificant things. So low risk. And then the AI, if you use it, it's not going to get you down to 5. It might cut that number in half. And then you're still just missing mostly clinically insignificant things, no real improvement in turnaround time. So if we had to score this one, doesn't score very well on the clinical side. So the clinical value, there's few misses, most are not clinically significant, and no change in turnaround time. So that's kind of a low clinical value. It's fairly simple to use. Almost everyone in our department has figured out how to use this. There are some settings. I'm not saying it's a one day and you're good to go sort of a thing. We did have to learn from this, but fairly simple to use. And then the return on investment's really related to triaging the ED and inpatients and so forth, and it doesn't seem to be helping us there. So pretty low return on investment. Despite that, it's very, very simple. And I think had we integrated with the work list, we might have seen something better. So pretend this was the work list. These are abdomen scans. Maybe it's finding something else. You have AI that's finding free air or some acute finding, and it flags them and moves them. I think this would help. 1, if it triage it to the top of the list, and 2, when you open it, you know right away this has a positive AI finding. That way you don't miss it. Right now, in reality, the AI can be positive in the widget and we don't notice it. You can actually miss it. So the AI is like, hi, I'm positive, and the human just doesn't see it. So that can that's what I'm talking about. The AI to human interface is weak with that widget. It might be strengthened with the work list, but I can't promise that. We haven't tested that directly. So right now we have one that detects PE, but you can detect intracranial hemorrhage, large vessel occlusions, aneurysm, cervical fracture, pneumothorax, incidental PEs, rib fracture, free air. This is all just from one vendor today. So it's not really the future. It's just the future for you if you haven't installed these. As you can imagine, there's probably going to be 20 or more of these in the same company in the near future. So that's kind of our future. And that brings us to this. What are these people doing in this waiting room? They're not waiting to get their scan. They've had their scan and they're waiting to get their result before going home. That potentially is our nearline future. I'm not sure how long it's going to take us to get there, but it makes sense to me that if you had AI running a bunch of things in the background, you might want to wait on that, possibly even a setup where we have a consultant ready to talk to the patient. So I think the future radiology waiting room could look a little bit different. Let's go on to a different topic here. We'll talk about natural language processing for reporting. This is something else that we've been using here. So as you know, all radiology reports, for the most part, universally have a findings and an impression or conclusion. And you can train AI on tens of millions of findings to lead to those conclusions. So you train it on both of those to generate the impression. So let's take a look at an example here. This is an HCC follow-up. So this is one of these ones where you're doing LIRAD's treatment response. So 2 lesions, we had to talk about how they've responded. And we also found 2 brand new lesions in this patient and a lot of other data that could have important incidental findings. So in this case, I'm clicking on conclusion. You can actually automate that. It takes about maybe 3 to 5 seconds and out pops an impression like this. And what's really cool about it, like I said, it was trained on tens of millions of reports. I'm adjusting it, by the way, right now. It missed something. It wasn't perfect, and that is real life. So I tried to give a real example. Sometimes it gets it right. Sometimes it gets it pretty close, and you just need to adjust it. So it does save some time. I think it takes a little bit of cognitive load off of the radiologist to be able to do this. We also have something very fantastic that's even better than AI, and those things are called residents and fellows. So at an academic environment, this is perhaps not as valuable as it would be in a private practice setting. So this graph is showing you that the higher the word count of your report and the higher the complexity, the more time, which is on the y-axis, that you can save. It kind of makes sense. If your report's really long, has a lot of findings, you're going to want to press that button and have it detect those kind of findings for you. So this is currently relevant to radiographs, CT, and MRI. It is a widget integrated with PowerScribe. So we're starting to get in this widget world. We have 2 different widgets running at UAB, and we could potentially see more of these. It sure would be nice if that was standardized. User training was pretty minimal for this because we're used to using PowerScribe or voice recognition software when we dictate. And the return on investment has to do with time saving for the radiologist. So how does this one score? I think the clinical value is potentially low. I have had it detect help me detect some of my own right-left errors. I think that's important. Like I said, it maybe reduces the cognitive load of the radiologist. It might reduce burnout. Okay, so that's clinically important to be able to do that. It's a very simple widget system and it's easy to integrate. So this one takes very minimal training. So the reason I gave it like a range of scores is right now it doesn't do a fantastic job when I'm working with the trainee. It might overwrite their report, and they're working on a solution for that. I think they will come up with that solution in the next few months. And when they do, I would give a very high simplicity score. And so the return on investment is a little unclear. We haven't personally tested this. It's supposed to save about an hour a day in the private practice world. I'm not so sure about that. I suppose it depends how frequently you use it. I find myself sometimes using it and sometimes not using it. So if I was more consistent with that, which may have something to do with how it's not handling the trainee reports very well, then it might improve my turnaround time a bit more, or my report dictation times would improve. So interesting technology, very, very exciting one that I like that's probably coming in the future. And there's a lot more you can do with it once you start to digitize all that data, and you can do more data analysis with the natural language processing. Here's a different example. So we're going to talk about AI and natural language processing for patient management. So we saw that with acute detection and triage, but not everything has to be acute. So I think there are leaders in this acute world, and I think we're in this range where some things are important that aren't necessarily acute. So this kind of comes to this opportunistic screening. So you're screening for a disease passively using patient encounters or images obtained for a different purpose. And this adds no patient cost or radiation if you're talking about CT scan. And thinking about CT, there's about 100 million a year in the US, and about half of those are chest and abdominal CTs. And there's a lot of information on this. So in this case, this is from a friend who does body composition analysis, and his team is able to measure bone density aortic calcifications like atherosclerotic calcifications, body fat like visceral to subcutaneous, muscle density and bulk, and liver fat, fully automated with almost 99% accuracy, like a less than 1% failure rate, and it matches really well had you hand drawn these. So pretty impressive technology. What do you do with this technology? So let's look for a couple examples here. So here's a patient that came in, I forget, their colorectal cancer screening, okay? So it turns out their scan was negative for colon cancer, and they have very low bone density, 63 Hounsfield is low. That puts you in the 99th percentile on the bad side of the spectrum. Similarly, their muscle density is also very low. Those things are actually predictive of a future hip fracture that occurred in this patient. Now, 3 months, you probably don't have enough time to get their calcium back in check, but if you track this back in time, 3 years earlier, 8 years earlier, 12 years earlier, you see this steady decline in bone density. So maybe there was an opportunity to do that. So that gives us an example of how potentially you could detect these things early and do something about it. This is for the aortic calcifications, which kind of relates to your coronary calcifications and your overall coronary disease. Agatston score scores how much and how dense the calcium is. So the initial CT was a 1500. 5 years later, it dramatically went up. And it's not just on this one slice. It does it over multiple slices. I'm just showing you the one slice. And eventually they had a myocardial infarction 4 years later. So this kind of shows you again how this can predict cardiovascular risk factors. So this is actually what it's doing. This is the cumulative incidence detecting aortic calcification. It's very good at predicting cardiovascular disease or time to death, even better than the Framingham risk score, which is really the most established clinical marker for predicting cardiovascular disease. So just a single CT scan can do better with just one of these metrics, which is really quite remarkable. Again, how do you deal with this? We haven't worked that out in our field as to what to do with this information, but some of us are interested in trying to figure that out. How do you interact with the patients? Here's an example of looking at a different type of body composition. So think about it. What causes cardiomegaly or enlargement of the heart? Ischemia, valvular disease, hypertension, these things cause you to develop cardiomegaly, and they're bad enough of themselves. Then once you have it, you're prone to arrhythmia, heart failure, myocardial infarction, and that can lead on to sudden death. So cardiomegaly is a time bomb in your chest. Okay, so what could we possibly do about that? Well, what if you made an AI algorithm that would detect this? So you might have it detect in 1 in 10 patients, the largest heart, putting it into percentiles. In this case, we're measuring whole heart, left ventricle, inner chest, and outer chest, and using that to determine if someone has cardiomegaly. So at UAB, we do 80,000 CT scans a year that are of the chest or abdomen, and this algorithm could work on either one of those, and you would direct the patients that are positive, essentially to cardiology in our case is what we're doing. So they're going to get an echocardiogram, an EKG, and a full clinical workup for this. A certain number of those patients are going to need lifelong management, probably all of them if you have cardiomegaly. Some of them will have ischemia and need coronary revascularization, whether that's a stent or cabbage, whatever that is. They may have an arrhythmia and need a defibrillator or a pacemaker, or they may have a bad valve and need valvular repair. So what is the score for this one? Pretty high on the clinical side. I mean, you are essentially detecting reversible cardiovascular disease, improving quality of life and survival, we think. We don't know for sure yet. It hasn't been fully tested, but high opportunity there. How about simplicity? Well, the algorithm's fully automated, but it requires this active participation. You're not actually sending this to the physician, you're sending it to a medical assistant who's sort of triaging this and saying, hey, this person has been seen in the clinic recently versus this person has not. And there are sophisticated ways to look at your EMR and sort that out. So it doesn't all have to be manual. A lot of this can be automated. So the more it's automated, the higher the simplicity score will go up. Does it have a return on investment? Absolutely. These are like getting right away an echocardiogram and this lifelong clinical management. These are patients that would not have seen a cardiologist ever before. And now they're coming in and getting these high dollar procedures that are changing their life. So it has a return on investment to the hospital. That's important. You actually have to have a return on investment, or why would someone use your algorithm? So this gets a pretty good score. Let's change it over now to NLP, and we're going to use aortic aneurysm as an example. So you just dictated a report and talked about intermittent right upper quadrant abdominal pain, and you just happen to mention that they have this aneurysm. Now, in this case, we said incidental findings as described above and didn't bother to put it in the impression. But even if you did, a lot of these patients are going to go on and get the appropriate thing, which is imaging surveillance of this aneurysm. And if it grows or changes, or it's just too big in the first place, they're probably going to get some sort of vascular repair like a stent. And then those patients continue to get imaging surveillance. That's the good situation, right? Whether you put this in the report or not, some of these are going to get lost to follow-up. They came in the ER and they left, and no one really picked it up from there. And a certain percent of those are going to go on and have an aortic rupture and potentially die from that. This is known. This has actually been shown in studies to be the case. How can we sort of minimize that rupture? So one thing you can do is NLP that's running on all of the reports. So this particular NLP algorithm is very specific and narrow. It's looking for abdominal aortic aneurysm, and it's characterizing the size. So you can train an NLP algorithm to do that. And then you would send it to sort of a care management software. I'm seeing different companies doing this, so I don't have a better way to describe it than that. Think of it as a dashboard where if you were a vascular surgeon medical assistant, you would access the dashboard and look to see, oh, we have 10 patients today that have not been seen by us before that have aortic aneurysms, and they will direct them to imaging surveillance and put them in the right pipeline. So this too has probably high clinical value, maybe not as high because this is a fairly uncommon event, but it's improved care coordination. It definitely reduces adverse events and deaths. And as we'll get to in a moment, it certainly has a return on investment. So it's fully automated, but again, it requires this active participation. This is just kind of coming out right now by several companies. Nobody's made it like widespread, but I think some of them are starting to catch on, at least in the United States. And the return on investment is these new imaging exams, new clinical visits and procedures, so that those are kind of big ticket items so it can pay for itself. So notice it's very interesting. It starts with the radiology report, and then we're somewhat left out of this. We don't necessarily have to be directly involved in the rest of the steps. So when these algorithms get sold, they often get sold to the non-radiology groups. They actually sell it to like the vascular surgeons, for example. So we saw it with aneurysms, but you can actually do this with other things. You can track lung nodules this way, particularly the ones that don't get follow-up. And they have ways of detecting, hey, this one has not been followed. There's nothing in the EMR saying this person's been followed up. So that's better than us saying, do the follow-up. They're actually checking to see was the follow-up done. We have a group that's interested in adrenal nodules because some of these are functional. We talked about cardiomegaly and detecting that as well. You can also detect coronary calcifications for atherosclerosis, or for example, cirrhosis, right? People die from the complications of cirrhosis, whether that's HCC or the varices or ascites and other things that kills them. There's a little bit of difference between those on the top and the bottom. Generally speaking, you could detect those on the top with NLP of the reports, as opposed to those on the bottom, you might use an AI that directly looks at the image to characterize these. It's unclear to me for cirrhosis which one is better, but for the other ones, it's pretty clear that like cardiomegaly and coronary calcifications probably should be looking at the images and quantifying that. So these have, again, the high clinical value and the return on investment that we talked about. One last group that we'll talk about is augmented intelligence for advanced cancer. This is a standard report. This is an abdomen on the left, chest on the right, one patient. Let's say it's like their third time point into cancer. And we're like slight increase in size of multiple liver mets, borderline enlarged retroperitoneal lymph nodes, no new sites of metastatic disease, unchanged large volume of ascites. Chest person says unchanged lung nodule metastases, no evidence of new disease. So how would you interpret this? I would probably say I hear slight increase in size of something. I'd probably put him in this stable disease bucket. We're not going to take him off of therapy for slight increase in size. But if we actually look at this patient over time with an augmented intelligence report, we can actually see over time that they're increasing and hit more than 20% growth, which triggers progressive disease. So this report's fully automated, has percent changes. All the measurements are done using AI and tracking things. It has a graph, it has a table, key images, actually a structured text as well. I think this is a better form of communication, and we'll document in a moment that it really is. How would this work? So picture an AI-guided viewer. If you come to the hands-on workshop, you will see this actually in action, a CT and MRI viewer. The user interface guides the radiologist using best practice workflows. And then the AI is activated when it needs to be. In this case, the AI is measuring tumors, anatomically labeling tumors, and then tracking the tumors over time. Conceivably, you would incorporate things like detection over time, but that's not yet in this particular platform. And then this leads to the automated reports. So you don't actually dictate this portion of the report. You click, 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 and I'll show you kind of an example of that. So here's an example. Here's a patient who has a bunch of liver metastases. Here's how it works. You decide, hey, I want to measure this one in the right lobe. You simply click on it. AI goes live. It zooms it in. You can edit it if you need to. As soon as you accept that, it presents the anatomy. It says liver right lobe, and that disappears pretty quickly because I'm showing you about real time here. We're going to go do a lymph node here, and we'll stop on the anatomy. So that lymph node's tucked in pretty close to some other structures, and the AI does a pretty good job of segmenting it. You could edit it if it didn't. And then here it says lymph node versus mass. It's saying lymph node, abdomen, retroperitoneal, and some more detailed anatomy is listed here as well. So this is twice as fast. Clicking is faster than dictating. It's got higher accuracy and precision, higher inter-observer agreement, and it eliminates data transfer errors. This is when you dictate 3.5 and it writes a different number in the report. That's gone because you're not having to dictate it. It doesn't go through this analog thing called a human. Improved standardization is also inherent in such a system. So what does it look like at follow-up? How does it help you find prior lesions? So the prior is on the right and the current is on the left. I'll show you what it does. First, it presents the prior lesion, and it takes you very close to where it's going to be, and you decide, as the radiologist, where to measure it. In this case, I didn't particularly love that segmentation, so I adjusted it on a nice zoomed image. As soon as I hit next, it jumps to the next lesion. And so it's taking me to this lesion on the right, and I'm deciding where I want to measure it, clicking on that, and moving forward. And this process is just repeated until you've gotten through all of your targets and your non-targets and other findings that are non-cancer as well. So it's very simple, it's very efficient, it reduces errors, and it eliminates these omissions. You know, if you've ever done this a lot, occasionally we forget to measure something someone else previously measured because it's buried in their report. That doesn't happen with this system. So it's very, very standardized, very efficient to be able to do this. We kind of talked about these reports, just a few more words on them, like why are they better? One, they're efficient, they're fully automated. It's higher reporting accuracy. That is me communicating with someone downstream. They can look at this report and really understand that slight increase in size actually meant progressive disease in this particular case. So it also has higher inter-observer agreement. 4 oncologists reading this same report are probably going to agree that it looks like it says progressive disease. So it's improved standardization. It calculates the total tumor burden. It conforms to clinical trial methods. You can make it strictly do that or loosely do that, depending on what your desire is. It's a highly effective form of communication, and oncologic providers prefer this. It's really interesting. It's digitized reports, so it can be converted into any language or adapted to low health literacy. So you could read in English and export in a different language without even being able to speak that language, because all you did was click, click, click on tumors and follow rules. So that's a pretty cool system for it to make it go worldwide. As I'm mostly talking to trainees here, I wanted you to see what it's like to be the attending radiologist. When you watch me work as an attending now, I have to read your prior report. I have to read your report, sorry, your current report. I have to read the prior exam report and look at the 2 time points of images. You don't look at any reports with this system. So as soon as you hit go, it displays what you have done on the current side and what was previously measured on the other. So it's very fast to check these. You just keep cycling through the target lesions, checking them, editing them as needed. But it's pretty obvious that these were, oh, that is the exact same periportal lymph node that the previous person measured. So it becomes very easy to standardize this process and review it. It's a very similar process for non-target lesions, which is being shown here. And then you have to decide, what category you think is going on for these non-target lesions. So it says present, and that is the case here. So very fast. This was actually 38 seconds if you timed it. It's the world's fastest method for trainee review. I'm not saying the whole report is 38 seconds. You still need to look for new sites of disease, double checking your trainee, and look for other acute findings. But wow, it is a super fast report. And you don't need to actually read reports to do it. You actually do what we're trained to do as radiologists, look at the images. So AI image findings are reviewed in the viewer. I think it's extremely efficient to do it. We have a version with sound effects that's kind of fun. And of course, you still get the same nice report that's highly standardized. So really nice way to be able to do this. So overall, does this work? We tested in a multi-institutional trial comparing standard of care to the AI method. It does improve accuracy. It does reduce major errors like right-left errors and data transfer errors or mathematical errors. It's twice as fast as dictating. It improved inter-observer agreement of the oncologist. Radiologists preferred it, and so did the oncologists. So that is dramatically changing the standard of care. So that's why it's going to get a very high clinical score. It's reducing errors and omissions, improving accuracy and reporting. That's very high on the clinical score. It's fairly easy to use. We train people in about an hour, but you'd have to train a lot of people to use this in a department to use it clinically. So maybe simplicity score is intermediate. And the return on investment is potentially high. You can gain new income from clinical trials. You can use systems like this for that. And then you can increase radiologist efficiency, which is really the return on investment here. How much? Hopefully it is that 2 times faster, but in real clinical life, it may not be quite that fast. Time will tell as we roll this thing out clinically. So what we talked about were key factors in success. The big ones were clinical value, simplicity, return on investment, and we had a scorecard for that. We talked about deep learning image reconstruction, both for PET-CT, where you could have faster scans or reducing radiation dose, or MRI that was faster scans, which was really good for reducing motion artifact and increasing patient satisfaction. We had AI triaging system. We talked about PE, not the greatest clinical value, but very simple. But we see these things expanding more and more and more. And just the simplicity of it makes it great. So we might have this new waiting room of the future where we'll wait to get radiology results. We talked about NLP for reporting. So we gave an example where you dictate a findings, press a button, boom, here's your impression. That was pretty cool. AI and NLP for patient management. So here we were detecting things like body composition or heart size and triaging them for care. And that would lead to new billing events downstream, as well as really help the patients. It was very similar using NLP to detect the aneurysm or some of the other things that we talked about. And lastly, we talked about augmented intelligence for cancer, kind of showing this CT and MRI guided viewer that, again, you'll get a chance to see on Friday for the hands-on event with guided workflow, AI, and automated reporting, ultimately really improving clinical care to be able to do that. So I think I'm not too far over, Jordan, but that is the end of my talk. So thank you, everyone.
Yeah, thank you so much, Dr. Smith. That was a really excellent talk. I know that we are right at the end of time, but we did have a few questions in the chat that overall on the same topic, so I'll condense them into one. So with so many applications across different systems for AI, are you concerned that any of these will become fully autonomous and replace AI or radiologist interpretation?
Not yet. No, I think that's many years away when we get to general AI before we're going to have to worry about that. What I do think about is, you know, there's a lot more algorithms coming, and I think there's going to be consolidation of these companies, and then it'll make it easier. We won't have like 5 widgets to look at. It'll probably be 1 widget. The other way to do it is a universal widget, which it would be very hard to convince people to do that. Everybody wants the customization. So I think the future is consolidation of these AI companies, so that, you know, it's just easier to be able to access them and not be overwhelmed as radiologists. But I don't really think I think our jobs are safe for quite some time. We'll be lucky. This just needs to keep up with. We have to have improvements in efficiency to be able to keep up with the demanding volume that we're seeing. About a 5% growth in volume every year. How are we supposed to stop that? We don't put out 5% more trainees every year. So we need solutions like this that improve our efficiency.
All right. Well, excellent answer. Thank you so much for joining us today. So we will be closing the Zoom for today. We'll be reconvening tomorrow for sessions with a team from the University of Maryland. We'll have Dr. Parekh giving a session on federated learning, and we'll have Dr. Paul Yee joining us again this year for pitfalls in MSK imaging. So thank you all for coming today, and we will look forward to seeing you tomorrow.